Hello everyone, today I'm back with different topic. Our today's topic of discussion is leishmaniasis. So leishmaniasis is one of the most clinically important and it's basically more endemic into certain part of East Africans and some Latin Americans. So this is one part of the infectious disease course. So what is leishmaniasis? Leishmaniasis is a vector-borne parasital disease that transmitted by the mosquito called sandfly. So it is a vector-borne. It is vector-borne, and the vector that transmits this leishmaniasis is called sandfly. And there are different forms of leishmaniasis you may heard at different your clinical settings, but the most important clinical settings and the clinically important form of leishmaniasis, the first one is visceral leishmaniasis. The second one is cutaneous leishmaniasis, and the third one is mucocutaneous leishmaniasis. Mucocutaneous leishmaniasis. So we have visceral leishmaniasis VL, cutaneous leishmaniasis CL, and mucocutaneous leishmaniasis called the MCLs. So these are the three important clinical features. So epidemiologically wise, when you see about the epidemiological transmission of this leishmaniasis, usually it is confined to some part of the world, and its annual incidence is not that much significance, but the disease is fatal. If it is left untreated, the mortality rate is more than 95%. So this leishmaniasis as a whole, its all prevalences between 50% to 90%, 90,000 annually. It is transmitted annually. So when you see about the key etiologic factors for leishmaniasis, basically we have 5 types of leishmaniasis to be identified, but the most important key species that can cause this leishmaniasis, for visceral leishmaniasis we have the primary causes, it is Leishmania donovani. Leishmania donovani species. For the cutaneous leishmaniasis, it is exclusively for Leishmania atopica. It is identified in Ethiopia. Leishmania atopica. So when you see about the life cycle of this leishmaniasis, as I mentioned before, it is a vector-borne disease that circulates between the sandfly and the human. So when the sandfly come to humans, and the sandfly in the salivary gland, she contains promastigoids. So there is a human phase and so these promastigoids entered into the human. So there are promastigoids entered the human. So when these promastigoids get entered into the human, the innate immunity system will be activated. So there are dendritic cells, there are neutrophils, and there are macrophages. So they will start to scavenge these promastigoids. So it entered into the macrophages, primarily the macrophages. So they entered into the macrophages. So these promastigoids entered into the macrophages. So they will change their forms from promastigoid into amastigoid. So this promastigoid it is infective to humans, and this amastigoid replicate itself inside the macrophage, and it will burst this and it infects another macrophage, and the cycle will going on. So this amastigoid it is infective for sandfly. So when the sandfly takes sample of the blood, she will carry this amastigoid. So in the gut, the amastigoid is changed into promastigoids. The amastigoid changes into promastigoids. So what are the pathophysiology or the pathogenesis of this leishmaniasis? So generally the clinical presentation and the pathogenesis is depending on 2 important factors. The first one is species type, the other one is the host factor. When I see the host factors, either it is genetic factor or immunity status of the patients. For immune compromised patients like HIV infected patients, their clinical presentation is usually atypical, and their course of management is totally different, and their pathogenesis is also different. For example, the visceral leishmaniasis an AIDS defining disease. If visceral leishmaniasis and HIV coexist together, according to the WHO, it is stage 4 classification. So what is the pathophysiology? The pathophysiology is still confined in the life cycle of the leishmaniasis. Now, after the promastigoid entered into the body, the macrophages engulf this promastigoid, and it forms what? It forms the phago. It forms a phagosome. So this one is the promastigoids. then there is a macrophage here with a big nucleus. It entered this. So inside the macrophages there are promastigoids. A promastigoid means there are some part of the plasma membrane of the phagocytes entered in with the plasma membrane. It will engulf it inside the cytoplasms. It will not united. Before uniting the lysosomes, it is called a phagosome. So these phagosomes you can find in the neutrophils, in the dendritic cells, again in the macrophages. But here is the special things. In the phagosome, this is happening in the phagosome. In the phagosome, the promastigoid is changed into amastigoid stages, but it will not form a phagolysome. This technically it should have formed a phagolysome, but this will not happen. There are special reasons that will not happen because there are immune evasion mechanisms. So what are the immune evasion mechanisms for visceral leishmaniasis? The first clinical important for immune and the only clinical important is there are important surface molecules that you can find on the plasma membrane or on the outer wall of the leishmaniasis. These are the lipophosphogylaicans and glycoproteins. Lipophosphogylaicans and glycoprotein 63. So what they do basically is they block the phagosomes to unite with the lysosome. So there will not be a formation of phagolysosomes, so the microorganism can freely replicate itself inside the macrophages. So what's now let's come to the specific pathophysiology of visceral leishmaniasis. So let me divide the pages. So let's see the specific pathophysiology of visceral leishmaniasis. So once the microorganisms or the drosophila insert this promastigoid, and the promastigoid changed into the amastigoid, then immediately the parasite start to replicate itself locally and it will disseminate. So its dissemination can be either hematogenous or using the lymphatic system. So using the lymphatic system in the macrophage, it will disseminate it. So it is basically mostly it invades reticuloendothelial systems. Reticuloendothelial systems. What are these reticuloendothelial systems? The bone marrow, the liver, the spleen, and the lymph nodes. These are the reticuloendothelial systems that are invaded because they contain this abundant amount of immune cells. So they are a favorable place and sites for the proliferation of this leishmaniasis. So the problem is, for example, if the leishmania replicate itself inside the bone marrow, there will be suppression or bone marrow suppression. So this patient could have pancytopenia, there will be anemia, there will be thrombocytopenia, and there will also a consequence of this leukopenia will happen. If it is inside the liver and the spleen, the normal physiologic metabolism of this liver and the spleen will be deranged. So these patients could have developed what? Hypoalbuminemia and hypergammaglobulinemia. So hypoalbuminemia or hypergammaglobulinemia. So these patients could have what? Edema can be their clinical presentations. The other one is, in the case of spleen, they also promoted hypersplenism. So it exacerbated the anemia. These patients usually present with the splenomegaly. So if it is left untreated, about 95% risk of mortality. And the most common cause of mortality is secondary infection and severe acute malnutrition. Usually these people are dying within 2 years of duration. Let's come to the cutaneous leishmaniasis. This is for visceral leishmaniasis, this is for cutaneous leishmaniasis. In the case of cutaneous leishmaniasis, like Leishmania aethiopica, the microorganisms or the parasite will not disseminate throughout the body. Rather, it is confined into local places. So it has two types. If the immunity system of the body is intact, or if it is weak, it has two presentations. Either it could be localized or it can be diffused. So if there are a localized cutaneous leishmaniasis, there will be a granulomatous inflammation. There will be a type 4 hypersensitive reactions. But if it is diffused, there will be diffuse nodular regions, non-ulcerative nodules will be opens. But if it is localized, there will be a granulomatous inflammations, because there will be ulcer will be formed. So these are just basically how the pathophysiology of the leishmaniasis briefly. So what are the clinical manifestation of leishmaniasis? So what are the clinical manifestations specifically for visceral leishmaniasis? So normally the incubation period for visceral leishmaniasis, it is a little bit protracted. Incubation period is usually protracted from weeks to months. So it has delayed presentations. Normally, according to different guidelines, the case definition of leishmaniasis is if a patient presented with 1. fever of more than 2 weeks durations, and if the patient has splenomegaly, or if the patient has lymphadenopathy, or if the patient has weight loss, or if the patient has anemia, or if the patient has decreased the amount of WBC, plus if the patient comes from endemic area or travel history to endemic area. So if these case definitions are fulfilled, the likelihood of being leishmaniasis is very high and significant. So leishmaniasis must be our strong differential diagnosis. But hematologic malignancy, sometimes malaria could have presented with these clinical presentations. So how do you diagnose visceral leishmaniasis? So the first one is this clinical diagnosis. We will see these case definitions. And the second most important diagnosis, it is we do serology. The famous one for serology, it is RK39. RK39 is, there are good thing and bad thing for this. But the bad thing is it has high specificity. For leishmaniasis. But the good thing is it has low sensitivity. Is around about 75 up to 95% of the case. So it is an antibody test, so it has low sensitivity. It means it might not detect the leishmaniasis at first try, so it has low sensitivity. And the most important one is it is confirmatory tests, or confirmation of the LED bodies, or confirmatory tests. So usually we are taking a body samples, and the most common confirmatory tests are, there are splenic aspirations greater than by bone marrow aspiration, and it is greater than by lymph node aspirations. So how we do splenic aspiration, bone marrow aspirations, we will discuss some in another video sessions. And the last one is we do PCR. Again, it is PCR. This is for visceral leishmaniasis. And how do you diagnose cutaneous leishmaniasis? Again, I will have a clinical presentations, and the other most important is it is slit skin smear. Slit skin smears, I can do biopsy. Again, culture also another importance, and we don't forget about PCR. This is our mode of management. So in economically limited area, skin slit smears and these body fluid aspirations are the most important type of diagnostic modalities for cutaneous leishmaniasis and visceral leishmaniasis, despite the clinical presentations. So how do you manage the leishmaniasis? So it has specific algorithms, and I hope most of you have to memorize this algorithm. So algorithm of management. So patient A come to your, like say, to your hospital, and you diagnosed using either splenic aspiration, bone marrow, or lymphadenopathy, and clinical presentation. So you would like to manage this patient. So how do you manage and how do you approach these patients? So the first important thing is you need to categorize the patients. Is it complicated patients, or it is uncomplicated patients, or is it a special group of patients? So there are uncomplicated groups. uncomplicated groups, and there are special group of patients like pregnant patients, children. These are special group of patients. So let's say the patient is 23 years old male, intact, no history of immunocompromisation. So this patient is an uncomplicated patient. So the next to do is you will do HIV test, because the management is totally different. So you will do 10 things. So the patient can be either positive or the patient can be negative, or sometimes the patient may refuse the test. So there are three options. So if the HIV test is negative, so if it is HIV test, I'm sorry again, if the HIV test is positive, it has different mode of management we will discuss. So we'll discuss about HIV, the management of HIV and visceral leishmaniasis. This is for visceral algorithm of management of visceral leishmaniasis. And the same thing is true for special groups. So you will do HIV test. So it can be either positive or it can be either negative. So if it is positive, we will discuss later in a separate paper. So let's say about uncomplicated malaria with HIV negative and refused. Both are managed at the same times. Both are managed similarly. If the patient refused, you will manage it as an uncomplicated malaria. So if it is negative, the first line of management is sodium gluconate. It is around 20 milligram per kg per day. You can give this medication IM or IV for 17 days. Plus, there is parmomycin. 50 milligram per kg per day, IM for 17 days. So you are going to treat them with sodium gluconate and parmomycin for 17 days will be the standard management for visceral leishmaniasis. So if the patient completes these 17 days, 17 days of management of this visceral leishmaniasis, you are expecting two things. So either the patient might be well, so they might be cured. So if the patient is cured and well, the next management is discharge. Advice about how the microorganisms get accused, about the precautions, and you have to discharge the patient. But what if the patient is not well? If the patient is unwell, you need to do test of cure. When do you do the test of cure? After completion of the sodium gluconate and the parmomycin. This means after 17 days. When you do see the test of cures, there are two possible options. Either the microorganisms can be negative or positive. It is negative, so you have to discharge the patient. But if it is positive, that means the microorganism is still inside the person, so you need to manage them again. But do you manage with like this management modalities? No, you are going to manage this patient with sodium gluconate for 16 days, and you are going to do weekly test of cures, usually by splenic aspiration. So you are going to do sodium gluconate with the same days, 20 milligram per kg for 16 days, and plus test of cure weekly. You need to follow the parasitic loads. So how do you follow the parasitic load? I will come back later and I will explain for you guys. So you need to manage these patients again. So if the patients again, if it is negative, that is good, and mostly it is negative, so you're going to discharge for these patients. But if it is stay positive, you're going to either the microorganism is adapting to this sodium gluconate, so you need to change the options what I'm going to explain here. So let's say this is a certain gravida to gestational age of 7 months, came to his diagnosed with visceral leishmania. So if it is HIV test negatives and she's in the category of HIV special group, so the first mode of management is liposomal amphotericin B. It is liposomal amphotericin B. Sometimes they call it Ambisome. So you are going to manage with Ambisome. So the doses, it is 5 milligrams per kg per day. Total, we are going to treat them with 20 milligram per kg for 1 week. For 1 week, we are going to manage them for 1 week. This is usually given with IV medications. So you need to treat these patients for about 5 to 7 days. So 5 up to 5, it is 25. So if you use 5 milligram per kg per day, at least you need to treat them for around 20 milligram per kg, around like for 4 days. So you need to manage these patients. And over day, the parmomycin usually provided about 4 up to 6 hours. it is not going fast, rather it is slow push. It is a slow push. So once you give this ambisome for these special populations, you have two options. So either the patient is well or it is unwell. So if it is well, you are going to discharge, but if the patient is unwell, you are going to do the test of cure. So when you do the test of cure, it could be negative or it could be positive. If it is negative, you are going to discharge from the list of this visceral leishmaniasis, and you will find another possible causes. But if it is positive for visceral leishmaniasis with a parasitic load, again you need to continue this ambisomes, not sodium stupogluconate. You need to continue this ambisomes with 5 mg per kg per day until the test of cure is negative. Until the test of cure is negative. There is no specific time here. So this is how you manage visceral leishmaniasis for clinically normal patients. But in some cases, the patient may present with relapsed visceral leishmaniasis. So relapse visceral leishmaniasis. So the first question is, how do you differentiate recurrent visceral leishmaniasis from relapsed visceral leishmaniasis? Put it down in the comment section. So relapsed visceral leishmaniasis, the same mechanisms and the same algorithms. You are going to divide them either complicated or uncomplicated one. So there are uncomplicated ones or there are special groups like pregnancies. So if it is uncomplicated, again you do the HIV test. So it can be either positive, or it can be either negative, or it can be either positive, or it can be refused. So if it is either refused and negative, the next mode of management is ambisome. So for relapse management, for relapse malaria, the first choice is it is ambisome. But is it only ambisomes? Nope. So you are going to give them 5 mg per kg IV for 6 days plus. You are going to bombard with all anti-leishmanial medication with parmomycin and sodium stupogluconates for 17 days. You are going to, for sodium, this one is for 13 days. I'm sorry, parmomycin is for 30 natural. Or you are, this is one option. Or you are going to need to provide this sodium stupogluconates for 14 days. Is also another option. So ambisome with parmomycin and sodium stupogluconates, you have to bombard them with. So the same thing is, after completion of these 14 days or 13 days, you need to check for test of cure. So if the test of cure can be negative or it can be positive. If it is negative, it is discharge, and if it is positive, I'm sorry, I messed up here. So after completion, you will check for the clinical condition. So it can be well or it can be unwell. If it is unwell, you are going to do the test of cure. If the test of cure is either negative or that is positive, if it is negative, you are going to discharge. But it is positive, you are going to give the sodium stupogluconate for 16 days. So the only difference is you are giving here for 14 days and you are giving here for 16 days again. The special groups, again you do the same things. You test for HIV tests, either it is positive or it is negative. If it is negative, you are going to give here ambisome. There is nothing different from the primary ones. The primary one, again you are going to give them ambisomes, and for special groups, again you give them ambisome 5 mg per kg IV for 6 days. And you will check it if it is well or unwell. If it is well, it is discharged. But if it is unwell, you do the test of cures, and if the test of cure is negative, you are going to discharge. And if it is positive, what? Again, you are going to give them ambisome 5 mg per kg IV per day till test of cure is clear. This is how you manage relapsed visceral leishmaniasis. It's a visceral leishmaniasis relapse. So the only difference is we are promoting sodium stupogluconates for clinically well patients. So here are a positive patients. How do you manage a patient with HIV and visceral leishmaniasis patients? Visceral leishmaniasis is an AIDS-defining disease. So you diagnose visceral leishmaniasis, you do HIV test, and it is positive. So how do you proceed? So the first thing is you need to check the parasitemia load, or you need to aspirate, determine the parasitic load. So over on the report, the parasitic load may come to your OPD with the result like 1+, 2+, 3+, 4+, 5 plus and 6 plus. This is a parasitic loads. So that is how it comes to your as a result. So when you say 1 plus, there are 10 Leishman or LED bodies per 1000 views, per 1000 fields. If when you say 2 plus, it is 10 per 100 fields. When you say 3, we are saying 10 per 10 fields. When you say 4, we are saying 10 per fields. When you say 5, we are saying that we have 50 to 100 LED bodies per field. And when you say 6, we are saying that more than 100 LED bodies per field. You have significant severe parasitemia in the case of 6 plus. So how do you manage this patient? So the first step is you have to determine the parasitic loads. But before that, why HIV and visceral leishmaniasis is something special? Why we care about it? Why special? So the reason we call it special is because of the following things. HIV patients have weak immunity. This can create the following things. The first one is this patient has atypical presentations. They might not present with like a fever of 2 weeks duration with splenomegaly and with travel history, blah blah blah. They might not present with like that symptoms. So this patient has atypical presentations. They might be afebrile. They may be afebrile. So only laboratory evidence may suggest for the presence of this HIV with leishmaniasis. The other one is this patient has low cure rates because of what? High parasitic load. And the other one is this patient is at risk of what? Relapse visceral leishmaniasis, and it is an AIDS defining disease. So we have to be much more careful in managing of visceral leishmaniasis for HIV patients. So we need to determine the parasitic load. So because we need to have the baseline, we need to follow the response. So once we determine the management, we are going to critically bombard these patients with all possible anti-leishmaniasis. So the first choice for anti-leishmaniasis for HIV patients is AmBisome, that is combined with multifocin. So we have AmBisomes, but our dose here is not 20 milligram per kg, rather it is 30 milligram per kg per day. 30 milligram per kg. So total dosage is 30 milligram per kg. So we are going to give them with 5 milligram per kg per dose per day. So when do we give these patients? So usually we are going to give them on every other day, on day 1, day 3, day 5, day 7, day 9, and day 11. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Yeah, for 6 days. We are going to give them for 6 days. So 6 times 5 is around 24. Not 24, it's around 30. Yeah, 30. So we are going to give them 30. So we need to provide every other day because AmBisomes has a long half-lives. In order to minimize, and we need to provide this around for up to 6 hours. The infusion hours should be for about this time. So since it has long period of times, we need to provide this. So we need to combine this AmBisome with multifocin. This multifocin is doses, it is 100 milligram per day. PO, it is a PO medication, especially for adults less than 25 kg. And we have to provide this multifocin for how long? For 28 days. So this is the first choice. But the problem is this multifocin might not be available in most areas. So the only available agent may be AmBisome. So you have to provide at these times. We need to, if it is not available, we need to provide AmBisomes, not 30, rather we need to 40 milligram per kg total dose. So how do you provide them? From day 1 up to 5, then we will give them on day 10, on day 70, and day 24. This is how we provide this AmBisome for these patients. So we have total of 8 cases. From here 5 cases, 5, 6, 7, 8. So we have 8 doses. So 8 times 5, it is 40. So we have 40 milligram per kg we are going to provide for these patients. But the critical point is these patients, when we are providing AmBisomes, we need to follow their renal function test and liver function test so closely because they are hepatocystic. The other one is, again, while we are treating the visceral leishmaniasis, we need to start ART medications as soon as possible. So let's let's complete this. So here in the case of HIV, we don't care about the patient is he well or not well. We need to do test of cure whatever it is. So when you do about the test of cures, there are two possible things. So the patient might be negative or there is no any sign of microorganism. For example, if it is initially 5 plus, but when you do after the treatment, if it is negative, immediately we are going to discharge this patient. But if it is negative, we are going to discharge these patients. But if the test of cure is positive, we need to follow the patient. So we have two options. The first one is the parasitemia. For example, if it is past two steps, for example, if it is initially 5 plus and if it is now 2 plus, there is a significant drop. But if it is 5 plus, but now after 28 of treatments, if it is 4 plus, it is 4 plus, there is no significant drop. So the parasitemia might drop significantly or not significantly. So the drop may be significant or not significant. If the drop is not significant or if it is not significant, so we have to change our management. So we need to start sodium stupogluconate with parmomycin. So sodium stupogluconate with parmomycin, the management option should be initiated. We have to provide for months, for 13 days. And if it is drop significantly, we need to repeat. So the management will be repeat. So we are going to repeat this ambisome with multifosine, or if we give them ambisome 40 mg per kg, we need to repeat the management. So once we repeat the management, again we need to do the test of cures. So if we do the test of cures, again it could be negative or it could be positive. If it is negative, we are going to discharge the patients. But if it is positive, so we need to start a combination protocol. It's a combination protocol. We need to start with ambisome plus multifosine plus sodium stupogluconate plus parmomycin for 16 days. We need to provide all possible anti-leishmanial agents for this patient. So this is how we properly manage visceral leishmanias in the case of HIV. So generally the major complications, just to give you a highlight, so the major complication is hematology. This visceral leishmania has, the first one is major complication. Let me write here. So the major complication is, it could be hematology complication. This patient is presented with pancytopenia. So pancytopenia related complication can be presented. So they have severe anemia, severe leukopenia, and severe thrombocytopenia. So these patients could have a bleeding tendency, DIC. High output heart failure might be their clinical presentations. Secondary bacterial infection because of this leukopenia can be presented. If there are a TB infection might be their presentation. They could have this neutropenic sepsis. They could have this skin and soft tissue infection. So because they have low immunity, even during in a procedure like splenic aspiration, during we follow this test of cures, this patient is at risk for developing of splenic ruptures. Usually splenic rupture is most common in the case of hypersplenism. So it is rare, but it is one possible complications. The other one is AKI and liver toxicity is also important things. And another most important thing is it is post-Kala-Azar dermal leishmaniasis. This post-Kala-Azar dermal leishmaniasis, it is a maculopapular rash, usually seen months or years after the treatments in their reservoir for the leishmaniasis after the treatment. So usually this is incidence is about 5 up to 10% of incidence, and they call it Kala-Azar because of the first times I think it is found in India. So finally, the prognosis, if it is left untreated, mortality is more than 95%. But if it is with a proper treatment, like by these algorithms, if the patient has no HIV, around 3 up to 8% of mortality rate. But if there are HIV co-infections, the mortality rate might be 10 up to 20%. And for a children, it's around 5%. But overall, the mortality rate of leishmaniasis with appropriate treatments for HIV and HIV it is 5 up to 12%. So it's a very fatal clinical condition. This is all I got for you guys. Thank you.